Thank you. So hi everyone, thank you for letting me attend this lunchtime session. I'm Danielle Collingridge. I'm based at the International Observatory on End-of-Life Care at Lancaster University. Sorry, 1 minute, let me just move my, there we go. And I'll be talking to you about my experiences during a Churchill Fellowship, which focused on palliative care in long-term care facilities and how palliative care can be provided in these settings during pandemics. I was in Montreal in October 2023, and it's really nice to be back, even if it is remotely. So I'll start off by telling you a bit about the structure of the session. I'll start with my background and then move on to care homes in England and end-of-life care and kind of COVID-19 in England and what our experiences were. And some of that will be findings from the Living and Dying in Care Homes study that I'm currently working on at Lancaster University. Then I'll talk a little bit about the Churchill Fellowship and then go into a bit of a background about care homes in Canada and Japan in terms of end-of-life care and COVID-19, and then finally move on to the 5 areas of recommendations that came out of the fellowship and the conclusion. So the photo on the right is from Oginomori West, which is one of the care homes I visited in Japan, and I apologise in advance for some of my pronunciation. It will not be superb, but this is one of the care homes that I visited, and some of the lessons I learned from visiting them are included in this presentation. So in terms of my background, I'm the current incumbent of the longest title in history. I'm the Dowager Countess Eleanor Peel Trust Sir Robert Boyd Fellow. And it's a 3-year postdoctoral fellowship, which was awarded for the study Living and Dying in Care Homes during the COVID-19 pandemic, what worked well and why. And what it looks at, and I'll talk a bit more about it in a minute, is what during the COVID pandemic could be implemented and what was effective and what wasn't from the perspective of care homes. Prior to that, during the COVID-19 pandemic, I was at the Cabinet Office in London as a subject matter expert on adult social care. And that's where the idea for my current work really came out. And previous to that, I worked on the PACE study, which looked at comparing the effectiveness of palliative care for elderly people in care homes in Europe. And that was in 6 countries. That was in Finland, Italy, Poland, the Netherlands, Belgium, and England. And my research interests really are in care homes and end-of-life care and what we can learn from other countries and making those international comparisons. So you can see on the right, this was staff from 6 of the countries that were involved in a PACE study at one of the annual meetings in Belgium back in 2018. So I thought I'd start off by telling you a little bit about care homes or long-term care facilities in Europe. And for many people in Europe, especially older adults and those approaching end of life, both the patient themselves and families prefer, if possible, to die within the home. However, for many people, as we all know, especially older adults, this is not always possible. And that could be from having care needs that are higher than is what is able to manage in the community, or it might be that support isn't available in the community, for example, through not having access to kind of informal caregivers. So when older adults go into care homes in Europe, what we kind of refer to as care homes in Europe, we can define them as a collective institutional setting where care is provided to older adults who live there 24 hours a day, 7 days a week for an undefined period of time. And the image on the right is the European Association of Palliative Care Atlas of Palliative Care in Europe. And if you're interested in learning a little bit more about palliative care in general in Europe, it's a really useful resource. It's very visual, lots of infographics to make comparisons, and it's actually very easy to read and very fascinating to read. And that's available online. So in terms of the types of care homes that we have in the UK, we have 2 types of care homes. We have nursing homes and residential homes. So in nursing homes, we have clinically trained nurses who are employed on site to provide medical care. And what we would call these in comparison to Europe would be type 2 care homes. And these are kind of the most popular type of care homes that are common across Europe. And then in England and Poland, we also have what we would call type 3 care homes. So these are residential homes where medical care is externally provided by a visiting district nurse, and general support for kind of daily living is provided by non-clinical healthcare assistants. So in both these types of homes, physician care or general practitioner care is, in England anyway, provided through the National Health Service, which is external. We don't have type 1 care homes in England, and these are found in Finland, Italy, Netherlands and Poland, among others. And this is where there's an on-site physician. So there's an on-site physician, on-site nurses, and on-site healthcare assistants. And I remember the first time I visited one in Finland, it was like walking into a hospital ward. It was completely different to anything I'd seen in the UK. So that gives you a little bit of context into the type of care homes that we have in England. The second thing to say in terms of kind of comparisons across Europe is in terms of funding. So you can see from the chart here, private for-profit care homes, private not-for-profit care homes, and public care homes. So those incorporated in the nation's healthcare system. And you can see in quite a few countries that were involved in the PACE study, at least, a lot of the care homes, or the majority of care homes, are either or equally split in some cases, but quite a few are from the kind of public health service sector. England is very different. So the majority of our care homes in England are private businesses, so they're private for profit, with a smaller proportion that are not for profit, so run by charities. And this has quite a few implications, because it means certainly in terms of conducting research, it can be quite difficult to access care homes. And there's also kind of more variation in care homes because they're run by very different businesses at times. So there are two things just to keep in mind. And then moving away from Europe, if we were looking at care homes in the UK, we have around 17,000 care homes, of which 5,000 are nursing and around 12,000 are residential homes. And they're supported by a workforce of around 750,000 people. And that will be a mixture of nurses, healthcare assistants, and administrative staff. And the number of care home residents in England is increasing. So it's gone up by 3% since 2022. Most of the care home residents that we have are aged, 80 years or over, and over half are female. And residents often have, I imagine based into Canada, high levels of disability, comorbidities, and dementia, or some form of cognitive impairment. So it's estimated that around 70% of care home residents have dementia or a severe memory problem. After admission, care home residents may live in the care home anywhere between a few days to a few years, but it's estimated that around 36% will die within 1 year of admission. In England, we're regulated by the Care Quality Commission, which ensures standards of care are achieved. And the average number of beds is around 30, but it can range from 1 to around 200. But the majority of care homes I've visited in the UK, you're probably looking at around 30 to 50 beds, which I think is from what I remember, a lot smaller than in Canada. So I'll talk a little bit about end-of-life care now, because I'm aware that not everyone here is from a palliative care background. And the focus of this research was kind of specifically on end-of-life care or palliative care. And what end-of-life care really aims to do is to improve the quality of life and reduce suffering in people with advanced or life-limiting conditions, as you can see from the WHO definition, which is in red on the right. Internationally, the term end-of-life is more commonly used to describe a shorter time frame before death. So usually the last few weeks or days or hours of life. But in Europe, sometimes a bit like care homes, the terminology changes, so it can be used. Certainly in England, sometimes it's used interchangeably, which can be a bit confusing. But when we think about end-of-life care, there's kind of three important points really to clarify. Firstly, end-of-life care is focused on the person. So it's not specific to one condition. It's not specific to, for example, cancer, or to one setting, for example, hospital. It can be provided really focused basically on the person. And secondly, end-of-life care neither hastens or delays death. It regards death as a normal process. Death and dying is part of a natural process. So it neither speeds it up or delays it. And thirdly, which I think is a very common misconception, end-of-life care can be delivered in conjunction with other therapies that are intended to prolong life. It's not at the expense of other therapies, for example. So it really focuses on the quality of life of the person with the aim to reduce physical, psychological, social, and spiritual suffering. And exactly what appropriate end-of-life care means is very much down to the person experiencing it. But a kind of consensus-based definition would include the things on the right. So those would be things like early identification of pain, assessment of pain, and that pain can be physical pain, but it can also be psychological distress, spiritual distress, and social needs. It can also support the patient to live as fully as possible until death, and it can do that through effective communication and determining goals of care. Support to the family. So end-of-life care isn't just about the patient, it's also about the family, caregivers and relatives during the patient's illness, but also in their own bereavement after death. It's applicable through the course of an illness, and it may change according to the patient's needs and their trajectory. And it recognises and respects the cultural values and beliefs of the patient and their family. And that's something that actually came up quite strongly later on in the fellowship, which I'll talk about in terms of the findings. It's available across all healthcare settings, ideally, and it can be provided by professionals with basic training on end-of-life care. So it can be generalist or specialist. So what about end-of-life care in care homes in England? So in England and Wales, 62% of older adults with a dementia diagnosis will experience end of life and subsequently die in a care home. So care homes are becoming a very popular place to die for older adults. And care homes are projected to become the most common place of death for older adults by 2040. So given these numbers, one would think that the push for end-of-life care and improving end-of-life care in this sector would be quite strong. And certainly in the UK, the National End-of-Life Care Strategy, which was last updated, I think it was published in 2008, sets out a vision for those approaching end of life regarding choices and where they'd like to die, and end of life care in care homes is very much referenced. However, there's a number of barriers to end of life care in care homes, and some of these barriers are kind of additional challenges that we find in care homes, and some are comparative to older adults living in the community. So firstly, for many care home residents, they may have multiple needs and they may have more than one condition. And as we've talked about, many have, or a large proportion have dementia, which can make making decisions quite difficult. So it can also make determining when end-of-life care kind of should begin or is identified a bit problematic. Unlike specific conditions such as, say, for example, cancer or organ failure, which have somewhat of a predictable trajectory from diagnosis to death, conditions in older adults, for example, frailty, are more slow. They're arguably kind of characterised by a progressive deterioration over a relatively long period, and that can be quite difficult to manage in terms of end of life. Secondly, most care is provided in care homes and it's delivered by a combination of qualified nurses, but also healthcare assistants. And certainly in England, healthcare assistants may have little formal training in end of life or limited knowledge of end of life care because training is quite variable across care homes. And something that you occasionally see as well is it might not always be clear what somebody's role is in end of life care, especially if you're a non-clinical healthcare assistant, and where those responsibilities towards the patient kind of start and end. In addition to that, engagement with healthcare professionals external to the care home, so within the NHS in the UK's situation, can be variable. So access to kind of specialist end-of-life care services can be varied. And then finally as well, care home residents, as I say, face very similar issues to older adults in accessing end-of-life care. I think there's a bit of an expectation that if you're an older adult, you will have come to terms with death and you will be aware that it's coming and kind of made peace with that and be happy to talk about your preferences. As many of us know, that isn't always the case. And certainly for care home residents, at times it can be difficult to kind of initiate those conversations, either with family members or with care home staff. So there's a number of potential issues that we encounter in care homes with end of life. So this slide goes into a little bit more about what happened in care homes during COVID in England. And there's a bit of a joke in the research team that I work in, that every presentation I do has to involve this slide. But I really like this slide because I think it really shows kind of what was going on in England during that time. So across the world, care homes were disproportionately affected by the COVID-19 pandemic, and about 40% of the total COVID deaths across OECD countries came from the care home sector. Certainly in England, 16.7% of all deaths were in care homes. 16.7% of all deaths in care homes, or around 45,000 deaths, involved COVID since the beginning of the pandemic. And what we can see from this chart, there's two really interesting things to take from this chart. In blue, you've got all deaths excluding COVID. In orange, you've got deaths involving COVID. And then the grey line is a 5-year average. And there's two kind of things to notice. So you can see in the first kind of few weeks of the pandemic, there was a huge increase in deaths, both defined as COVID related, but also defined as non-COVID related. And there's two reasons for that, or two potential explanations. The first is that those in blue were actually dying of COVID, but testing wasn't available or accessible, and that's why COVID wasn't discussed in the death certificate. Or it could be that due to staff shortages, issues accessing external healthcare, deaths were higher that weren't related to COVID. The second thing to notice is if you look kind of in the middle of the graph, you can see the number of deaths. I think it's like in March 2021 goes that much further below the 5-year average. And the reason we think that was occurring was because fewer people were going into care homes because they were scared from what they'd seen on the media. So more people were remaining in the home. And that's why deaths were kind of lower during that time. So that really shows what was kind of going on in England during that time. So in terms of end-of-life care and the policies that were issued by the government, we had quite a few policies that obviously impacted end-of-life care and influenced end-of-life care in care homes. And the policies that were mainly put in place were guidance on end-of-life care in terms of visitation, removing the requirement of relatives to be tested prior to visiting a resident who was at end of life, and reiterating guidance regarding the creation and application of advanced care plans during that time. However, the extent to which these policies were able to be put in place is kind of unclear. Sorry, I'm just having a bit of a faff with my, there we go. That's better. Sorry about that, having Zoom issues. So in terms of what studies since COVID have found, in the case of residents approaching end of life, during which visits from relatives were allowed, one survey found that 18% of care homes surveyed did not allow visitors at end of life, and those that did, 51% experienced challenges in providing bereavement support to relatives. The pandemic also really limited the ability of care home staff to deliver relationship-centred care through disrupting the assessment and management of social needs, in addition to physical and psychological needs of the resident. Visiting restrictions and a kind of shift to virtual forms of communication interfered with the ability of relatives to really engage socially and provide emotional support near end of life. And staff shortages and absenteeism, increased workload and stress reduced the time and resources available to provide kind of practical and emotional support. As you can see on the right, this was one of the announcements that was made early on in the pandemic by Matt Hancock, who was our health secretary at the time, regarding changes to visitation policies. So in addition to that, difficulties managing relationships with relatives occurred during visitation, many of whom the relatives felt a sense of guilt, helplessness, and a sense of urgency to see residents at end of life. Staff tended not to be offered or couldn't access adequate emotional support and weren't allowed time to kind of really process their emotional needs related to resident deaths, of which there was a huge increase in. Care homes are often or have reported acting within the fears of implications of reporting COVID-19 cases in terms of damaging the kind of reputation of the care home. And the article on the left is from a care home that was in the media where 17 had died in the past 2 weeks. So again, that would have been on BBC News. So it was very much, in terms of the media at the time, it was all over the media how care homes were performing. Initiatives during this time to provide online learning in terms of end-of-life care during the pandemic led to an increased awareness and understanding of advanced care planning and increased confidence and willingness to talk to residents about advanced care planning. However, having the time to complete the training was very much a barrier because it was occurring at the same time as the pandemic. So that gives you a bit of background into some of the policies that were in place, certainly in England during that time. And then I'll just talk briefly now about the study that I'm working on at the moment and share some of the quotes from my current research. So as I've said, the current research aims to kind of better understand the response to COVID-19 in care homes in England to inform future policy and how we deal with future pandemics. And it had 3 stages. The first stage was to review policies that were issued to care homes to see what the government was asking care homes to do. And the second stage was to do 8 case studies, so it was in 8 care homes in the Northwest, and explore what worked well for them and why. And that included 24 semi-structured interviews with a range of staff. So that was managers, nurses, healthcare assistants, and administrative staff. And finally, we did a transparent expert consultation with a kind of wide selection of stakeholders, including residents, relatives, care home staff, and kind of researchers in the area to really further develop these potential policy recommendations. So the quotes that I'm just going to show now are from the interviews that we did, and they're related specifically to end of life. And the first quote relates to kind of visitation and making it the exception. So the care home manager said, "Yeah, of course we did. I mean, you can't. I don't know how any sane person could say, you're not coming in case you bring COVID to somebody who's already dying. You know, what difference is it going to make? Some of the things we did in our care home, we probably shouldn't have done. But in hindsight, now I think a lot of care homes wish they'd done it that way, because, you know, you think of how yourself in that situation and what are the risks really." So that was a care home manager kind of reflecting on bending some of the rules to allow visitation at end of life. The second quote relates more to kind of social distancing during that time. And the activity coordinator said, "There's one person that sticks in my head. It was a lady she was in a bedroom here on end of life and her family couldn't come in. And they were stood at the window with the priest watching her die, and we were in the room trying to hold it together. We couldn't hold it together. You wanted to hug the relatives and say sorry, but you can't. I'm not going to lie though, there was one woman who I was very close to, and I'm very close to the family, and she died. And I said, I can't stand here and watch you break down on your own. And I did hug her, because I can't watch somebody physically break down and just stand there. It's not a human thing to do. You can give me the guidance, but I'm going to support that person." So there you can see the difficulties many staff felt in abiding by social distancing guidelines during end of life care. The role of wider health services, especially in terms of advanced care planning, came up as well. So in this quote, "We got a lot of DNRs," so DNRs are do not resuscitate orders. "We got a lot of DNRs sent in the post. When people were explaining, the doctors were ringing up. I'll never forget this. They explained to a lady who had dementia, well, she had memory loss, and he said to her, 'So we need to speak to you about do not resuscitate.' And she said, 'What does that mean?' He said that you don't have to go to hospital, and that's what that means. And she agreed to that, to not being resuscitated. So they lied. The doctors lied about what a DNR actually meant. They told her it just meant you don't go to hospital if you get COVID." So that's obviously quite a worrying quote in terms of both mental capacity and consent, and explaining DNRs. And then the final quote was regarding the use of technology and kind of using technology as a substitute for physical presence. "Not even the ones that were dying were allowed to have any visitors, which was heartbreaking. It was just heartbreaking, and watching them, seeing their parents or grandparents dying on a phone. Oh, I'm really sorry, but no, it's not going to be a night kind of thing. It's, do you want me to video call you? It's how to reassure someone that's dying on a video call and you not being able to be there." And that's where we got close to all the families. So again, the issues there regarding end of life and how to use technology as a substitute. So it was this research and the experiences I've kind of had at the Cabinet Office which really made me keen to explore how other countries managed during COVID and what the UK could learn. And to do this, I applied for a Churchill Fellowship. So a Churchill Fellowship is a funding stream in the UK, and it's named after Sir Winston Churchill, and it funds up to 2 months of learning from around the world by travelling overseas. And it really focuses on discovering new ideas and best practices worldwide, with the aim to share recommendations and turn these ideas into action in the UK. And one of the characteristics of this fellowship, which makes it really popular, is there's 150 awarded each year, and it's open to all UK citizens. So you don't need to have an academic background or any kind of qualifications to apply. It's really open to anyone who has a passion for improving care in the UK or life in the UK. It's more than just health. There's 10 different award themes, including an open theme, and I applied for the palliative care theme. So the project I applied for was really to look at end-of-life care and care homes in a post-COVID-19 world. And there were 3 areas that I was particularly interested in Canada and Japan. And the first was how care home staff either provided or worked with wider health services to deliver end-of-life care, how local public health policymakers protected care homes, and approaches to maintaining contact between residents and their families and friends during the pandemic. So I spent 3 weeks in Canada in October 2023, followed by 3 weeks in Japan in March 2024. And in each country, I met with researchers, healthcare professionals, care home staff, basically anyone who was happy to speak to me, I met with if I could. And I collected their views and recommendations and kind of collated them to form the 5 themes we'll talk about at the end of the presentation. And I chose Canada and Japan for 3 main reasons. Firstly, both countries have an ageing population similar to the UK and kind of vaguely similar long-term care systems, which make comparisons meaningful. Secondly, the approaches and kind of ramifications of the COVID-19 restrictions on care homes were slightly different to the UK. So in Canada, concerns were more related to residents not receiving care or appropriate care due to staffing shortages rather than necessarily the spread of COVID-19, which was more maybe more of the focus in the UK. And then in comparison, Japan's experience was kind of mediated through kind of early care home closures and pre-existing surveillance and infection control protocols, which we'll talk about in a minute. So there are 2 kind of very different approaches there. And finally, in both countries, both are kind of similar to the UK in terms of their current level of end-of-life care integration. So the Global Atlas of Palliative Care rated the UK, Canada and Japan as 3 of 30 countries at an advanced stage of integration. So in terms of the kind of levels of palliative care, all 3 countries were relatively similar. So I'll talk for a moment about end-of-life care in care homes in Canada. Obviously, there's a few friendly faces you may recognise on that photo. So in Canada, care homes, very similar to the UK, are the least preferred place of death for the general population in Canada. And again, older adults often prefer to die either at home or in an end-of-life care facility, depending on the severity of the health issues. So in a 2023 report, Access to Palliative Care in Canada, it stated that 58% of Canadians who died in 2021 to 2022 received end-of-life care. And the framework on palliative care in Canada acknowledged the potential for unmet end-of-life care needs, specifically noting that, excuse me, adults with dementia were among the least likely to access end-of-life services compared to those with cancer, so that was 39% versus 77%. Canadians aged 85 years and older were less likely to receive end-of-life care than younger generation or younger people. And only 34% of residents in long-term care that had less than 6 months to live received end-of-life care. So again, very similar to the UK. Potential barriers to providing end-of-life care included staff capacity, education and support, and the need for external resources. And obviously, medical assistance in dying or MAID, the process that allows someone who's eligible to receive assistance from a medical practitioner in ending their life, has been available since 2016. Excuse me. So in terms of COVID in care homes in Canada, obviously many of you have experienced this and were there for it. So I'll just be brief on this one. As I've said, concerns related more to residents not receiving appropriate care due to staffing shortages, rather than necessarily the spread of COVID-19. As stated, Canada was one of the many countries where care homes were badly affected by the pandemic. And by April 2022, there'd been around 16,000 COVID attributed deaths in care homes, representing around 4% of the estimated care home population. Ontario and Quebec experienced particularly high rates of infection and mortality in care homes, and severe understaffing led to the deployment of the Canadian Armed Forces to provide care to residents in 47 facilities in Quebec and 7 in Ontario. Policy recommendations and guidance in Canada were very similar to that in the UK, so restrictions on visitation, increases in infection control measures, and reduced mobility of staff between settings, which is something we also brought in the UK. Asymptomatic health workers and inadequate staffing levels resulting in the use of mobile teams that travel between care homes was something that was identified that contributed to the spread of the pandemic, again, very similar to the UK. And certainly in Ontario, staff movement between facilities fell very sharply after an emergency order by the Ontario government, limiting long-term care staff to a single facility. Care homes in the media were portrayed as kind of lacking resources, with the COVID pandemic having a very negative effect on the residents' health. And for relatives, the enforced separation from residents resulted in significant distress. And at times, communication between care homes and relatives was felt to be inconsistent. So that's a bit of an overview of the situation in Canada. So in Canada, I visited Ottawa, Toronto, Hamilton, Montreal, and Saskatoon for my visits. So moving on now to Japan. Japan, in terms of place of death, is relatively similar in terms of preferences. So around 44% of the general population in Japan would prefer to die at home, 15% preferred a hospital, 19% preferred a palliative care unit, and around 12% preferred a nursing home. However, certainly among the care home population, death is more common in hospitals for older adults, in contrast to 4% actually occurred in care homes. So transfers to hospital are quite common. The government has been promoting end-of-life care in care homes through offering a financial incentive package. And these incentives are dependent on the care home having a few characteristics. So that will be employing a full-time registered nurse, having a 24-hour on-call system for nurses, having a policy in end-of-life care that's communicated on admission to residents and their families, holding seminars on end-of-life care for the staff, and having a private room available for end-of-life care. And since these financial incentives have been introduced, the number of older adults dying in a nursing home has actually increased. However, it's very much dependent on the nursing home and the resident that this improvement happens. So, for example, having a resident with preference documentation that's documented. So there are a number of kind of characteristics that make it more likely the financial incentive has been a success. But despite this, there are still many challenges. There's a lack of end-of-life care strategy among care homes, a lack of standardised training for staff, and limited information on like the use of end-of-life care medications and things. Unlike Canada, there's no form of medically assisted dying that is legal in Japan, and the issue is currently not being debated at a government level, which that's something we'll talk about a little bit more in a moment. On the right, you can see a photograph from a train journey to Chiba University from Tokyo, and against all the odds, I actually made it to my destination. So I'm very, very proud of that photo. In terms of COVID, Japan is an interesting case study. We would think, given Japan's aging population, it would suggest that there would be a higher proportion of the population that were more vulnerable to COVID-19 infection and subsequent death. Now, COVID-19 did spread to care homes in Japan. However, in comparison to Europe, the number of people that were infected remained relatively low. And not only were the number of infections relatively low, but there were also fewer deaths from the infection in care homes. For example, COVID-19 deaths in care homes accounted for at least 14% of COVID deaths in Japan in the early stages of the pandemic, compared to more than 20% in the USA. And during the initial months of the pandemic, it looks like less than 0.01% of care home residents died of COVID in Japan, compared to 0.4% in Germany, 5.3% in the UK, and 6.1% in Spain. So it's a lot lower. And when we talk about why it was that Japan performed differently, there's been a number of reasons that have kind of been suggested. And one of them is the society-wide use of face masks. So face masks are commonly worn in Japan, and the early lockdown of care homes, which we'll go into a little bit in a minute. And it could also be argued that the spread of COVID was potentially limited due to the cultural differences. So in Japan, there's very little culture of hugging or kissing greetings, and there's a huge adherence to guidelines and adherence to rules. And if anyone here has ever been to Japan and been on the metro, it's completely different to London, because everybody is on one side and nobody breaks the rules in terms of cutting in. So it's completely different, certainly, to the mentality in England. And one of the stories that I remember telling to colleagues in Japan was about a care home in England where there were visitation restrictions. So they'd let, there was a brother and sister, they'd let the brother in to the mother's room, and what they didn't realise was that the brother had opened the window on the first floor of the care home, and the sister had climbed up the trellises and entered the room. And they only found out when a care home staff member went in to give a glass of water. And I remember telling this story to colleagues in Japan, and they were absolutely aghast at the idea that somebody would break the rules like that. It was just completely unheard of. So that should give you a bit of an example of how strong the adherence to guidelines and government guidelines is in Japan. But there are three other reasons that we think the relatively low number of COVID cases in care homes could be explained. One of them is that there's quite a well-established system in the government agencies at each local government level, that focuses on elderly care. So there was a very clear roles and responsibilities in terms of who was looking after care home residents. Secondly, because of this, there are very effective communication routes between care homes and the regulatory authorities. So kind of local centres of disease control and prevention really acted as a go-between for care homes to local and national governments in terms of communicating guidance. And finally, since 2000, care homes were required to convene an internal infection prevention and control committee at least once every 3 months, to prevent outbreaks of infectious diseases such as seasonal flu. So having these committees meant that there was already, in some cases, care homes that were in kind of semi-lockdown, with it being January, February, before the pandemic really hit. So care homes to some extent were already a little bit protected. And one thing to note about these committees was they included a variety of employees, including non-medical care workers. And that's been one of the reasons that has been suggested for Japan performing as it did. So I'll now move on to the findings of the study. Now you've had a bit of context. So there are 5 areas that I really kind of felt came out of the fellowship and the 6 weeks of visits. And it would be impossible to kind of give every example. So what I've tried to do is give an example from each country. And the 5 areas, the first was improving knowledge and openness about end-of-life care and end of life in general. The second was creating a culture of continuous improvement among care home staff. The third, supporting resident independence, autonomy and empowerment. The fourth was incorporating and developing trust with relatives. And finally, the fifth was developing internationally comparable research to inform evidence-based policy and practice. So I'll go into each one now. So the first finding, improving knowledge and openness about end-of-life care, really emerged, firstly, I think through Canada, because it was through the kind of strengthening palliative approach in long-term care team, which is led by Professor Sharon Casalainen in Ontario, Professor Tamara Sisman in Quebec, and Professor Paula Hunter in Saskatoon, among other provincial partners, that really brought that home. So the SPAR LTC programme is funded by the Canadian Institute of Health Research, and its approach to end-of-life care in care homes that really focuses on empowering care home staff and families to provide personalised and high quality care for residents. And there's 2 elements to this, as we can kind of see on the screen. So the first characteristic that really struck me about SPAR LTC was how the programme brings together kind of best practices in terms of end-of-life care within care homes that have been tested and implemented in care homes in other countries. And then a team would test these practices in Canadian settings and adapt them to fit a local context, or a kind of made in Canada approach. And an area that I really kind of got to grips with this was the development of the educational resources for residents and families. So on the right, you can see a leaflet from SPAR LTC and an information leaflet for residents and relatives on end-of-life care, specifically for residents with dementia, specific to Ontario. And this was actually put into practice in the care home that I visited on the left, St Margaret's. And it was really fascinating to talk to staff who currently use that material to discuss end-of-life care with residents and their families, and seeing how the pamphlets really kind of proved valuable in guiding these conversations and setting out what to expect in different phases of end-of-life and what this would mean for residents' care. A second part of this really came about at the Sherbrooke Community Centre in Saskatoon. When I visited, it was running a session from an external speaker for residents and relatives on how to make a will. So in addition to kind of providing knowledge, the session actually allowed residents to make their own choices and supported the kind of enactment of these choices by facilitating access to legal representation. And certainly in the UK, care homes can be at times seen as somewhat gatekeepers to kind of not necessarily information, but to accessing external services. And something that really struck me about this approach was how much it empowered residents to have not only having this information, but actually have their preferences recorded. And certainly during the pandemic, as we've talked about, having documentation, be that legal or be that advanced care planning, is really important, and making sure that those decisions are documented and enacted. The second photo kind of fits into this theme, but it's from a slightly different approach. So this was in Japan, and the bag there belongs to somebody called Mr. H, who was an end-of-life care end-of-life home care patient in Osaka. And despite not living in a care home, this was one of the formative experiences of the trip, because Mr. H had written a book about assisted suicide based on his experiences and reflections as somebody who is approaching end of life. So as we've kind of said, unlike Canada, Japan hasn't legalized or engaged in any discussions about legalizing assisted dying. And Mr. H's reflections on this was that he found it very difficult as somebody approaching end of life to not have somebody to speak to openly and honestly about his willingness to die without judgment. And the value of actually having somebody to speak to was incredibly important. And the person he actually spoke to and felt comfortable talking to was his home care nurse, who visited once a day. And it really brought into focus how important it is for care home staff, or just the amount of knowledge care home staff are expected to have, both in terms of not just about end-of-life care in older adults, but also having these conversations, having the softer skills to have these conversations, but also the implications of these conversations in terms of goals of care and signposting residents to, or those at end of life, to different services. And Mr. H chose not to be photographed, but he did let me photograph his bag, which says, "Turn your wounds into wisdom." And he felt that very much summed up his journey that he'd had as he was approaching end of life. And I think that, again, that just really brings back how important it is that older adults, certainly approaching end of life, have access to this information and are able to speak to somebody about it. The second finding that emerged from the visits to Canada and Japan was the importance of creating a culture of continuous improvement. So certainly in the UK and many other countries, including Canada and Japan, care homes demonstrated an incredible resilience in adapting and managing the challenges they faced. And part of this was finding new ways to work as a team. And I think, as I look back, I think many efforts to improve end of life are sometimes quite limited to training and kind of knowledge exchange, and they can undervalue the role of empowering and supporting care home staff, kind of adopting a whole care home approach and working towards a common goal. And without that, I think education alone in end of life care won't necessarily improve it. And an example of this was from Strensrud Lodge care home in Saskatoon. And this was a photograph of a whiteboard that was used during the morning team meetings. And as part of the facility's commitment to monitoring and continuous improvement, the care home manager had focused on improving rates of hand hygiene among staff. And he'd found a way to check if staff were washing their hands, and recorded it on a routine basis and reported it back to the team, identifying and celebrating positive change. The numbers have been changed for the photograph that I took, but it was a really good example of seeing a whole home approach of trying to improve care from a collective point of view. The second photo on the right is from Oginomori West Care Home in Japan. And the picture is part of a recruitment booklet. And the recruitment booklet was very much focused on investing in care home staff education, and developed a ranking system which staff members could gain qualifications, and these qualifications were linked to increases in salary. So in return for completing a qualification, staff members were required to remain working in a facility for a pre-specified amount of time in return for the cost of the qualification. But it really showed how important it is to find ways to recruit and retain staff members. And that's certainly a challenge that we have in the UK, where staff turnover can be quite high. And what was really nice about the system is it allowed a career pathway through kind of a personal evaluation system, on the basis that the harder somebody worked, the more they would be recognised. And the qualifications also transferred across facilities. So by having these standards, staff could evaluate their skills and knowledge and take that to other facilities if need be. What was also especially interesting was that the progression started from care home staff members with no experience at all. So it was very much based at different levels. You could be a health care assistant with no knowledge of palliative care, or you could be a registered nurse, and there were options available. So I think, again, really important, and especially important for end-of-life care. The third finding, or the third theme that came up through the two visits, was the importance of supporting resident autonomy and empowerment. And for older adults residing in a care home, in general, and even more so during COVID, end of life can lead to kind of feelings of disempowerment through a lack of control and a lack of lack of certainty on what to expect, alongside the kind of physical and mental deterioration and feelings of fear and anxiety. And in some cases as well, relatives may very well feel in a similar position. So the example on the left is from Sherbrooke Community Centre in Saskatoon, which follows the Eden alternative approach to care, which I won't talk about too much in detail here. But specific to COVID-19, the care home uses a village model whereby there's 9 to 10 residents who live together in houses. And this house is attached to the rest of the care home by an internal street. And a small grouping of residents in each house really supported the formation of kind of a family-like household. So it meant that residents had control over how they organised their day, how they cooked, as opposed to fitting into an institutional routine. And within this, daily living assistants were assigned to a specific house and remained there. So during COVID-19, this model was fascinating to hear about, because it basically meant groups could be locked down and isolated together. So people were able to kind of not be isolated in their own rooms, which obviously has implications for mental health. And I thought that was just an absolutely lovely way of really empowering residents and keeping independence and autonomy as much as possible. The second example in terms of empowering residents is on the right. And it's the 5 types of meals that are available at the Gourmet Kinea Social Contribution House, which is a care home in Osaka, which is known far and wide for its gourmet quality of meals. And it's something that they're extremely proud of. The selection of meals, I actually tasted all of them. They put on a spread of each of the 5 meals available for me, which was an incredible experience. So the kitchen offers 5 types of meals, depending on the preferences and the needs of the residents. And the names of the 5 meals translate loosely to beautiful, heart and mind, easy, master, and kind. And they're specifically prepared for residents with different levels of dysphagia. So on admission and at regular intervals, depending on the progression of the resident's care needs, staff conducted an assessment to check which meal would be most suited to the resident's needs. And what I really appreciated here was the tailoring of the meals to the resident as their ability to eat deteriorated, while keeping the quality of the food and standard of the food high, so that this was not compromised as the resident's condition deteriorated. And in addition, the naming of the meals really removed any negative connotations associated with difficulties and ability, and was very, very well presented. It was one of the most beautiful meals I think I've actually had in many years. And these 2 examples really show the efforts to maintain resident autonomy within a care home. So the 4th finding, which is again extremely important, really relates to developing trust with relatives. And in the definition of end-of-life care that we saw at the beginning of the report, the role and the importance of keeping relatives involved in end-of-life care is a central part of that definition. And certainly during the pandemic, this was extremely difficult. And there were 2 examples of this that I wanted to share with you. So the first one is the morning room at Maimon Des Geriatric Centre. I apologise for my pronunciation on that one. The morning room was prepared during the COVID-19 pandemic, and it's located next to the morgue. And many of the residents at the care home are of the Jewish faith, and the morning room was really created to kind of accommodate the death practices associated with religion. And in particular, the room provided a private, secluded space for relatives to kind of spend time with a loved one's body. And it was accessed through a designated lift, and every element of the room had been extremely well thought out from the perspective of the needs of the relative. It was also separate to the rest of the facility, so it ensured that social distancing and infection control rules could be put in place. And I thought this was a fantastic example of really bringing into relatives into the equation. The second example is the thank you wall at Oginomori West Care Home, which we talked about previously. The thank you wall was one of the highlights of the visit, and something staff were extremely proud of. So whenever a resident or relative felt grateful for a member of staff, they would fill in a small pre-made form on the left, and this would be put into the staff member's envelope. And the board also had photographs of each staff member so that each staff member could be recognised. And this was a simple but effective way of allowing staff to be recognised for providing good care, but also ensured that relatives and residents felt that they had a voice and agency. And something that really came up out of Japan was the focus on using positive examples to build on, rather than examples of negative behaviour to use and build on. It was a real focus on developing the positive. I'm aware we're running out of time, so I'll just whiz through this. The final theme related to developing internationally comparable research to inform evidence-based policy and practice. So the photograph on the left is at the Canadian Hospice and Palliative Care Association conference as an honorary member of the SPAR LTC team. And the photo on the right is a translation into Japanese of the 6 Steps to Success programme, which was part of the PACE study that I worked on previously. And again, both really illustrate the importance of internationally comparable research and building these networks, much like we are today. So I've not got many more slides left. So these 5 themes resulted in 12 recommendations, all of which are listed in the report, but there's 2 I'd like to focus on. So they're both in bold. And the first one is creating and promoting initiatives at national level to normalise discussing end of life. And certainly Mr. H's story really brought home the importance of being open to discussing end of life. And I think that's extremely important and will go very far to improving end of life care, not just in care homes. And the second one was developing ongoing relationships based on trust between care home staff and relatives. And again, specific to COVID, the role of trust between relatives and residents and care home staff was extremely important. And in all the examples that I think we've seen, developing that relationship with relatives is central to improving end of life care. So final thoughts, there are 3 kind of main takeaways from this. Firstly, the characteristics of good end-of-life care during pandemics are the same as when there's no pandemic. And if a care home recognises that importance of end-of-life care, it can embed those practices into routine care and are much more likely to continue in periods of external pressures. Secondly, efforts to improve end-of-life care that focus on improving knowledge alone are unlikely to result in improved care. And what is needed is staff empowerment and support. And finally, building on a previous point, there is no end-of-life care without the resident and the relative. So the report is available here, along with all the references that have been used in this presentation. And just a final thing to say thank you for listening to me talk about my research and the Churchill Fellowship. I hope it's been useful and provided a bit of insight into the experiences in England and Japan and Canada, which of course you already know. There are my contact details, which are also in a report, if you have any questions or would like any further information. And finally, there's just some disclaimers regarding my funding. So I'll stop sharing my screen there, and I hope I didn't overrun too much.